start. So, welcome everyone. I'm hoping those who are coming will find us on the way. This is a busy week for us. We apologize for months we have skipped, and this one is our last session for the year 2025. So, another one we still to plan. For others for 2026. But for didactic presentations, since 2022, we have been doing them until today. It's been a long journey with the support of our partners, Eco India. They have supported us so much with technical support as far as hosting these so much important sessions. So I like to thank you for joining us even in this one. We hope this is not our last session as palliative care is concerned, knowing the need and demand for palliative care in our context in Eswatini, in the SADC region, and the African continent, and actually the global context. There is no way we can rest meeting and having these interdisciplinary meetings where we discuss palliative care issues. But we are still looking at possibilities to look for 100% case presentation sessions for next year, whereby we will be unpacking case by case every month. So now we practicalize this didactic presentation we had, and sometimes reflect on some of the topics we have covered. So yeah, we will be looking at that. But I hope more update will be shared as time goes on. We will have the opportunity to do that. I'm hoping with those who will be with us, we will update our iEco platform for next year's presentation. But uh, chances are we might focus on IDT meetings where we'll be discussing in-depth cases from facilities, from the community, and everywhere. And this is the most interesting time we're going to have together, putting into practical and sharing our theories, theoretical understanding, and practical knowledge and experience gained in providing such services. In that note, this is another important week for the Kingdom of Eswatini. We understand we have passed October, our month where we commemorate World Hospice and Palliative Care Day. But tomorrow we have a special time where we will be meeting at Eswatini Hospice premises and commemorate as a country the milestones that we have achieved as a country as far as palliative care, and paving ways on how we can maneuver going forward and build our nation that will be resilient to this NCD and meet these palliative care needs that is growing in demand in our country. Yeah, and do better and more. So some of you, I hope, will meet tomorrow. But for today, we wanted to end the year with one of the very important issues. So this year, we were focusing solely on doing end of life care. So we have looked more and more of it, and we unpacked it from that experience to where we are now. To summarize the whole journey, we started from what is palliative care. We went with the patient through, and we have uploaded this. You can check on Mahlangu MNS. Yeah, if not mistaken, a YouTube channel. You can find most of the recordings we have had. But for us to sum up well, we have our social worker, Mercy Shabano, who specializes on providing palliative care. And she will take us on this last topic we are going to do, which is on bereavement. So we'll be looking around on grief and bereavement today, especially for patients who have lost and those who are at end of life. So we will be looking at that today. So without the waste of time, I would like to give her and also apologize for the last time for this year to say that we are not going to have a case, but we are looking for a robust time in next year whereby we might even don't have didactic presentations, but they have most of the time dedicated to unpacking and analyzing real life cases so that we can improve the quality of life of our patients using the information we've been learning since 2022. For those who have not had the privy to be in our didactic sessions or eco sessions till 2022, may I invite you to visit my YouTube channel, Mahlangu MNS, and then have that time to listen to those recordings. But so that but you can still attend the sessions even next year and have a nice time and experience on how to manage palliative care cases so we can improve the quality of service we are providing to our clients and our skills ourselves as clinicians. So with that, may I request Mercy to, all right. With that said, may I request that Mercy, you take us through today's presentation, and then we will have more discussions on it after, as this is our last session for the year, but we're looking for a better one next year. So Mercy, I hope you are ready. You can go ahead, madam.
Thank you, Mr. Mahlangu. Good afternoon, colleagues. My name is Mercy Shabangu, as I have been introduced by Mr. Mahlangu. I will be sharing a presentation today on bereavement support to families post the death of their loved one. I will request Mr. Mahlangu to kindly share the presentation.
Okay, can I try to get to it? Where are we? Yeah, moment, I'll pin it very fast. Ooh, wow. Is the one written bereavement support?
Yes.
Let me try open. A moment, team, I'll be opening soon. A moment. I'll be opening it soon. Yep. Oh my God. Yes. It's coming. It is coming. There I am. All right. Can I share now? Please, when I'm dropped, please let me know in my WhatsApp. I will not have the opportunity to see. I don't know whether it will appear well. I don't know. Let me do like this. Yep. Yep. I don't know if you can see it now.
Yes, Mr. Mahlangu, it is visible.
All right. All right.
Mm. Can we move to the first or to the second slide actually?
Okay.
The next one. Thank you. So colleagues, as I mentioned today, I will be presenting on bereavement support to families post or after the death of their loved one. Bereavement, maybe I can start by defining what bereavement is. Bereavement is the period after a loss during which grief and mourning occurs. The time spent in bereavement for the loss of a loved one usually depends on the circumstances of the loss and the level of attachment to the person who has died. So the primary purpose of bereavement support is to help normalize the grieving experience or process. It is also to help reduce feelings of isolation, to develop healthy coping strategies, and to facilitate healing and adjustment to life after the loss of a loved one. Interventions provided during bereavement support may help decrease anxiety, distress, and grief whilst enhancing well-being. So bereavement support should be tailored to the needs of the families and offered to those who wish to receive it. Can we now move to the common grief reactions? So now we are going to look at the common grief reactions. As we have mentioned earlier, that during bereavement, grieving occurs. So these are the reactions that we can expect to see or to hear from the bereaved individuals or family members. These reactions can involve mental, physical, social, or emotional responses. The reactions can include feelings of numbness, anger, guilt, anxiety, sadness, despair. And in some instances, the individual can experience difficulty in concentrating. It could be at work or at school. There are also eating and sleeping problems where you find that there is a change in patterns, routine when it comes to sleeping and eating. Individuals and families can also experience loss in the pleasurable activities. And at times, there are also physical problems and even illness that can occur as a common reaction or as a reaction to grief. So I think the reactions that I've mentioned, colleagues, are applicable to all age ranges from children to adults, which is why, as I've mentioned earlier, that it might affect concentration, whether at school or at work. It is important that we monitor school or work performance of the bereaved person, because this is one of the areas where we can be able to identify or determine if this individual is struggling with grief, or we can be able to identify how the grief has actually impacted them. So when providing support as a professional, it is important to determine which of these reactions are present, be it for an individual or for family members. This will help us to provide assistance and interventions that align with the need or the state of the affected person or family. And as a professional, it is important to refer accordingly when and where needed. And now we are going to look at complicated grief briefly. So another thing that is important to note, colleagues, when providing bereavement support is that for some individuals, after the loss of their loved one, they experience complicated grief, which may include reactions that can last maybe up to 6 months or even longer. And in some cases, they can even mirror those that are seen in major depressive disorders. These are some of the symptoms that can help us identify when an individual is experiencing complicated grief. So these symptoms are feelings of disbelief, in some cases where the feelings of disbelief are prolonged, as mentioned about that It could be 6 months or even longer. And here you tend to find that the individual struggles to comprehend or accept that their loved one is gone or no more. It could be a normal reaction if only it was short term, but because now you find that it is prolonged, then it proves to be complicated grief. The second, please, Mr. Mashango, please go back to, yes, thank you. The second, can we go back to complicated grief? Thank you.
Yes.
So another symptom that we can identify complicated grief with is distressful memories for longer periods. So some of these memories can include how their loved one suffered throughout the course of the illness, or maybe during the end of life, probably the last hours. So if maybe they suffered in some type of way, their loved ones, then you find that they then keep maybe experiencing, or yes, those distressful memories. And sometimes it is how their loved one died. If it wasn't peacefully, if maybe there was gasping and choking or anything like that occurring, you find that those are some of the memories that keep coming back to their loved ones, hence resulting to complicated grief. Another symptom is feeling unable to move on with one's life, where you may find that family members or an individual may struggle to continue with their life, like reaching certain milestones in life that are expected of them, or you find that they struggle to continue with their projects or to even pursue other or new initiatives. This can also include struggles with remarriage in case the bereaved person lost their spouse. So you might find that they are unable to, at some point, move on and get married again. Or with others who maybe stopped working because they were taking care of their relative, they might struggle to go back to work again. And then the last symptom is yearning for the deceased. You find that for prolonged periods, the bereaved family member yearns for the deceased loved one. Can we now move to how we can then support or how we can identify the bereavement support needs of the family members and individuals? The first one is we can start by exploring the initial grief experience and current state of each family member. This helps us to understand the immediate impact of the loss and how the person is currently doing or is currently coping with the loss. The second step could be exploring the relationship with the deceased. Now, this helps us as professionals to understand the depth of the loss by exploring the kind of relationship that they had and their shared history. And then the third one is observing and asking about emotional and physical reactions to grief, which are the ones that we've mentioned above. So we do this to be able to assess for emotional well-being and how the grief is manifesting with each family member or with each person. The fourth step is identifying coping strategies and support systems in place. We can do this in order for us to be able to maybe identify resilience factors and the presence or absence of a support network. And then the fifth, I think it's the fifth one, is respecting and acknowledging cultural and spiritual beliefs around grief. This promotes cultural competency, which is very important in palliative care. And it promotes us to respect the cultural context and explore the role of faith in the grieving process, so that whatever interventions that are provided do not clash with an individual's beliefs or cultural norms. And then the sixth step is identifying daily functioning and practical needs which will help us to understand how the grief is affecting the daily life of the individual or of the family member and identifying unmet needs. The next one is identifying emotional risks. I think it is important to note that when it comes to this step, we need to use it appropriately and with sensitivity so that we can be able to screen for signs of complicated grief, depression, anxiety, or even risk to safety in cases of maybe suicide. The next step is assessing for coping strategies, where we can be able to identify how the individual is able to make meaning of what is happening, especially towards their healing process. So here we can explore the sources of comfort, hope, and even future support needs of the individual and other family members. And then the last step is to assess for willingness for continued support and follow-up. This will help us to determine the need and openness to ongoing bereavement services for the family members. Can we continue to the next slide? Thank you. Now we are going to look at the strategies for bereavement support. So after having conducted the assessment, engaged the family members, these are some of the things that we, or even before, these are some of the things that we can be able to do to reach out to them during their time of bereavement and maybe mourning. One of the ways that we can use is by providing family counseling. So when conducting a family counseling session, we need to make sure that a safe space is created for open communication and active listening to each and every family member's experience. It is also important to focus on understanding the family's communication patterns, their coping styles, and the impact that the loss has on their relationships. So as health professionals, we can also help the family members to share their memories and to express their emotions without judgment, either from the healthcare professional or from another family member during the session. We can also help them develop a shared understanding of the loss, what it means to them as a family, and encourage them to create new rituals to honor the deceased. This will help the family members to rebuild their sense of self and even family identity. So this is another approach that can help facilitate healing for the family and individual family members. Another way that we can use to provide support, bereavement support, could be individual counseling, because sometimes after conducting a family session, you might find that some family members are struggling more than others and they need more assistance and attention. So we can then provide individual counseling. So when we provide individual counseling, it is important to use techniques like active listening, exploring of memories, identifying and processing emotions, where the client is or the individual is able to name those emotions. Some of them could even include guilt. There are cases where individuals are struggling with guilt after the death of a loved one. And then during such sessions, we can help them to develop healthy coping mechanisms. Individual sessions help to accommodate an individual's loss and to help them find a way to reinvest in life rather than simply getting over the death of a loved one. Another strategy that we can use is bereavement follow-up contact. So with bereavement follow-up contact, we can use follow-up calls or contact, which can be made from, say, maybe 3 weeks after the passing of the loved one to up to 6 months. depending on the needs of the family members, and how they are comfortable with the arrangement. This kind of support is actually a very helpful one because it can leave a person feeling pleased, grateful, and even comforted, feeling that they're not alone. Someone is able to acknowledge their grief. And then the last strategy is to make use of support groups. So individuals and family members can be referred to either online support groups, to telehealth groups, or even in-person support groups that deal with grief and bereavement. These support groups can help the individuals to maintain important relationships, to facilitate reflections about themselves and others, basically how the journey of the illness or how the death of their loved one has changed or impacted their lives. These sessions also help to strengthen an individual's self-determination. So, with support groups, individuals are helped to create meaning and to manage different feelings of grief by promoting a more positive self-perspective. In conclusion, it is important to ensure that individuals and families are provided with or are linked with services and resources designed to assist them in coping with emotional, physical, social, and spiritual pain following the loss of a loved one. Thank you.
Oh, thank you, Messi, for such a brief, straightforward presentation. Yeah, this is as you are presenting, I'm just thinking in my mind about the patient or the victims of loss, the general one that everybody can think of, which is the patient. I'm also pondering on the issues of the clinicians themselves. But what is our experience and how do we deal with such? Because fortunately enough, I've been in my life been a client and been a service provider, and I've experienced that maybe sometimes the public complaint may be related to clinicians suffering or struggling with grief. But allow me, colleagues, to give you this opportunity to ponder on this topic. What is your take? What is your experience with these patients or with this phenomenon of bereavement, grief and bereavement? What are the gaps you have noticed? What is it that we are doing well? What is it we still need to do? And how best have you tried to do this? Or how have you been affected? So can we share in reflection to this topic? We have more time to talk about it. So can you share? I can't see much, but you can just unmute and share. What's your take in as far as bereavement is concerned? Grief and bereavement. This is one of my favorite topics in palliative care. I usually borrow Dr. Mpo's words in that when governments fails to invest in palliative care, they must increase their budget towards mental hospital budgets. And daily, in my experience in providing palliative care, this one becomes true. Because when people have what we call recurrent losses with exposure or risk or high risk of mental health disorders, that requires us to increase the bill for mental health facilities. But then, actually in our context, let's increase the budget for psychiatric hospital. If we can't invest in palliative care, then let's deal with the outcomes. One of the reasons I usually quote that statement is that this is one of the problems we have with our clients, with our relatives, with ourselves as clinicians. We have a serious problem with grief, loss, and bereavement. As clinicians, I've been to an inpatient unit. There's a client. I've noticed the clinicians there, they incur loss after loss almost in a week, 3 or 4 or 5 times in a week. I don't want to mention the COVID era, but 3 to 4, 5 times a week, they are incurring client loss. And unfortunately, I'm not sure of debriefing sessions and bereavement time. I'm not sure of a long leave after. The schedule keeps on going. And the question is, when we see nurses misbehaving, or when we see clinicians having a rude attitude and anger, have we tried to ask ourselves, have they not gone to what we call complicated grief? But let me leave it to you, colleagues. Can we talk about it? You know? Mm-hmm. Mm-hmm. Today's topic is so nice and true about us and the patient. This is one of the topics that touch both the provider and the recipient of the service. Yeah. Mm-hmm. What can you say? You can raise your hand, you can share. This is one of the serious issues we go through. And unfortunately, this is the most neglected. Maybe we may need to do certain study to find how true is this hypothesis. In Eswatini, you incur a loss, you are on your own. Nobody to run to. No time for bereavement. You are on your own. In short, in Eswatini, bereaved people are at risk or indeed they suffer neglection. Nobody follows up. You grieve and bereave on your own. You undergo bereavement, counseling, and care for your son. What people are saying, what can be done? How can we, what is your experience as far as grief and bereavement is concerned? It may be a patient experience. I know some of us here have been providing palliative care for some time, but let's share. I don't want to point say so and so do what, but yeah. I can see most of us are here. So can you share? What is your experience? I remember one of my colleagues saying, now I will not recommend chemo for my patient because all of them that have started chemo, they've passed on, or their situation has deteriorated very fast. Bluntly, that's an easy thing to say. But deeper, that's a symptom of a grief, incurring loss after loss after loss. and then disappointment. Could we be victims of such at some point? Such that we ended up deciding to withhold service to deserving patients because of our experiences. How have you handled yours? Yeah. I was just sharing, colleagues, my thinking, what is going through my mind post this. I'm seeing people exiting. I don't know. Yeah. Anyone who may wants to share some, a question, a suggestion, or a comment. Mhm. I can go to one, two. Yeah. Okay. Mhm.
Good afternoon, Tim.
Yes, Margaret.
Yeah, well, thank you very much, Mercy, for this summary presentation on bereavement. And my little contribution is that until and unless we decide to really help ourselves, it is difficult to help other people who are going through bereavement, because it's easy to say, no, you will heal, because you think you have also maybe healed, yet you are also still grieving. And your grieving is suppressed, if I may say, because you never confronted it.
Mhm.
And this thing catches up with us in the long run, because once we are prompted because of somebody else's bereavement, one, we're unable to help. Two, we might find ourselves breaking down because we never dealt with our own. In short, I'm saying it's easy to overlook the process and not tackle it as we do need to tackle it, but there are more negative effects in our life. Even talking about it, we don't want to talk. So and so is gone, and I'm moving on. The question is, are you really moving on in a healthy state? Or we are just moving on like a wounded soldier, and somewhere the infection is still building inside. So that is quite dangerous in our lives. And I pray that we really take note of this and we heal ourselves. Because move is a bullet if I'm still buckling my own bereavement, which I've been attended to. It becomes unbearable when it explodes. So thank you for this. We need to as individuals so that we can able to help our clients and all those who would come to our hands in need of the service. Thank you.
Thank you, Madlenya. Yeah. What a time. Yeah. Anyone else who may wants to share? This is a nice, but it's very serious issue. You know? What have you seen? Grief, loss, bereavement. The clients are going through. They are simple. There are things I've never I've talked about some. I've done them before, and I've got some feedback from the clients about it. But I can testify and say they really work. For example, in the immediate times of the loss or during the period of loss, the issue of presence, the issue of reassurance, the issue of support, even if it's not monetary based, it works. It has some impact on how our clients gonna cope. But most of the time, we neglect it. I've come to understand that in the hospital setting, there are different cadres of people hired there. We have doctors, pharmacists, nurses, and we have support staff, especially the orderlies and stuff. And I've got to understand that most of the time, the people who are always up and down, the orderlies are always there. And most of the time, they build certain relationships with the clients. And I've recognized how important the support staff can be in supporting bereaved families. They play a major role. But I'm not sure if they are remembered on how has these recurrent losses affected their lives. I don't know. But we are looking about grief, loss, bereavement. And when we're talking about loss, we are not talking about maybe the loss of a loved one alone. The loss of body shape, the loss of the precious gift that you wish to contain for a long time, the loss of the valuable thing in your life. It's so hard. But how do we move forward? I made a statement. If we don't invest in palliative care, managing grief, we need to increase the budget for psychiatric hospital admissions and care. Dealing with the depression and other mental health disorders that could be triggered by failure to manage well grief and loss. I haven't yet done a study too. I don't know if there's any yet done to check the post-trauma or post-effect of COVID and the experiences. Has it built our resilience or has it exposed our society to more mental health issues or to more psychiatric disorders? Such that we may think now we have a healthy society, only to know we have a very sick society, mentally sick society. We don't know. Where are we standing? If then we think we are in a standing with a healthy society, what guarantees that as to that? Were there any shock absorbers of that severe recurrent loss? Were our people capacitated to cope? The social worker today mentioned the issues of coping capabilities. Were our people ready to cope? In the midst of the anxiety and trauma of that pandemic, were our people there? I don't want to mention the issue of there was a pandemic, there were these NCDs taking our people too. So it's a loss after loss, diagnosis after diagnosis, statistics after statistics, all factors combined. Do we have a health society? What are we doing with it? How can best cope? As clinicians, we are hit hard by everything. And Margaret is mentioning the issue that we need to take care of ourselves. How far are we able to do that? Is the family set up? Is the work environment? Is the church or religious space capacitated and favorable to help people cope? Because we may think we have healthy people, but we have very sick people. And out of the sick people, we are expecting politicians and everybody to contribute to the advancements of the nation and the growth of the economics and the healthy life. We're going to see more divorces coming. We're going to blame marriages and stuff, but you'll discover that even the counseling issues during marriages, you may find there is no screening of any mental health disorders done, and people who are sick get married, and we're going to blame a lot. Where are we going? The generation we are raising, are we investing enough to take care of them? Are we sure they have the good coping mechanisms? Mercy mentioned the issue of support groups. Do we have them there on the ground? Are they capacitated to handle? what is their grief shock absorbing level? Can they? I'm just thinking, I'm thinking around, what is your take? What is your experience on what is happening? Or what has worked that you have tried and put on the ground that we can learn out of when we are taking off the patient? I've mentioned one of it, the issue of being present, the issue of being supportive, the reassurance words. They help those who are undergoing loss and grief to find a standing ground. Yeah, boo. Yeah. What can you say? Yeah, boo. I don't want to point, but I will try to say, Hilda, I don't know. Is there something you can share as far as this topic is concerned? Hilda, sorry to pinpoint you, but just I want to help us say something. Is there anything you can like to say in as far as loss, grief, and bereavement, and the support? You can unmute and share. Yeah. Yeah, I see others have just joined us. Yes, Hilda, is there anything you would like to share? Okay. Non-Tobago. Okay. Okay. You're welcome, Hilda. You are also free to put your comments on chat too. You're welcome. Yes, Non-Tobago, is there anything you can share? Your experience, the gaps, or any interventions or things you've seen have worked in helping deal with this? This is our last session for the year. What a journey, what a year we have had in this topic. Yebu, yebu. So is there anything you want to say in Tobago? You can unmute and share, or you can put it on chat. We will read it for the team. Yeah. I can see Mr. A, my lecturer. I know you are the mental health specialist, I know. But I would like you to share. We're looking at loss, grief, and bereavement, and looking how best we can support those who are undergoing it, but then also considering the issue that as far as the clients or the families, we may perceive them as the recipients of the loss, but also the providers, we also go through. But the issue then is, what is this that we can do better to support ourselves or to support the loved ones? I don't know if Mr. Lamini can say something or a comment, and as far as loss, grief, and bereavement is.
Oh, okay. Thank you, Mr. Mashang. I am using a trustee's laptop now. She has just gone out. Yes, there's something called a facade or a facade. That is when you just go out and meet some people, you cannot really say what they are feeling, what they're feeling inside, but they would like you to think everything is fine, everything is well with them. So it is what we are used to not showing our true feelings. So I think the one of the best ways we can do is to be true to ourselves and seek help, seek the necessary help, so that we as health professionals can also be in a position to help other people. Just accept that this is something real. It is something we're undergoing. So we have just to be true to ourselves, and also remember that this uh, grieving process, it is individualized. It does not go according to the book or what is written in the textbooks, but it's per individual. So just to take time with that individual, providing the necessary support, asking them what you can do for them, checking on them. Some of those I think they can work. But as long as we are able to be true to ourselves and to our feelings, because if we just keep on pretending, this, like Magezoto was saying, it will keep on haunting. It will keep on haunting us. And yet, if we just accept that we are undergoing such a stage, then healing is guaranteed someday. Thank you, Mr. Mashara.
Thank you, Nkosi. Yeah. Yeah, as Mr. Dlamini said, that we need to be true. I'm just asking, I'm one person who is engaged in church, Sometimes I listen to people testifying. There's more behind, but you find out none will be done. And one will testify in church and go hang himself. Yeah. We have seen and said people, oh, we were playing, it was nice, but later you've discovered he has taken Master 900. And you find that nothing much, the loss, the experience was too high. And then he found the other alternatives. But yeah, thank you, Mr. Dlamini. It's a very serious topic, and most of the time we neglect. For us who in palliative care, sometimes we feel like, okay, now the loved one is gone. We depart to look for the next one. And then we depart looking for the next one. Nobody cares on, are we all genuine? I have made an assumption before and said, maybe for us, sometimes we are said to be rude people. Maybe it is that most of us are in the profession not clean, but hurt. So we are here to displace what we have gone through. And most of the time you'll hear a clinician say that, why are you so weak? You need to do APCD. You will hear a clinician shouting at a patient in the morning on a Monday after payday. So, we go through a lot. This reconciliation with self, finding ourselves and dealing with, as Mr. Dlamini is saying, being true to ourselves will take us far. Anyone else who might share? I saw Mr. Dlamini was coming, but then he has left. I don't know if I would be leaving someone behind who would like to share something, but allow me, colleagues, to appreciate your presence. Palliative care, it's an approach that will help us help ourselves. It will also help us help those who can't help themselves. Actually, it's a vehicle for service. If you want to achieve good quality of care for these patients with life-limiting and threatening conditions, embracing palliative care into all the Betitumen and Dorothea Oren's theories, and then embrace this approach to take care of these patients. It can help us a lot It has the economic, social, spiritual, psychological, and physical benefits to both the patients and the providers. So we need to embrace it and use it in the care of the patient and in taking care of ourselves. So that one will help us improve the quality of our lives and improve the quality of life with those faced with serious illnesses. The issue is that we may be living in countries where the healthcare status is not good, or the economy is not performing as we wish. But the question is, what best approach can we have to improve the quality of life of these people who are faced with life-limiting, faced with intense grief and loss? And one thing I will emphasize as we leave this session today is that we may have the notion and think that, or maybe loss will happen with my patients when the loved one is gone. But today I want us to live with understanding that loss and grief start on the day of diagnosis, when the news or the bad news are broken, or the understanding and experience that my body is not performing as I usually experience is true. That's when loss begins. And most of the time, with the more information shared on public, anticipatory grief starts when one experiences the signs and symptoms of a life-threatening or limiting condition. So whenever they come to hospital to inquire about their status and condition, as clinicians, we need to brace ourselves with good communication skills and be ready to break the bad news in the right way, not to help the patient cope with the disease trajectory itself, but also to cope with the loss and grief, so that they can experience quality of life regardless of the disease trajectory or prognosis. And we need to embrace this public health issue, this grief and loss, and integrate it into public health, and ensure that all we can do is to improve the quality of life of our patients. So let's understand that it doesn't start at end of life, but it starts right on diagnosis. Actually, the experience even pre-diagnosis, it's already there. That's why you'll see patients going up and down, inquiring sometimes on their conditions. So with that said, as healthcare professionals, we cannot leave ourselves behind. We need to embrace it and understand the loss. And we need to have that open door policy to say, I'm going to ask help where it is needed and on time. So self-care, actually, let me read what Sister Bata, taking off self is also important, as you stated, that sometimes we end up shouting at patients. So it is important that you identify that you have a problem and seek for help before it's too late, before we end up in a depression state. Care of carer is important. We need to love ourselves, spoil ourselves. I wish I could get an opportunity to, so we get this wellness unit in the facilities to say, you know what, can we revitalize them? Can we shout the message? The founder of PSI has this issue, understanding of the concept of what you call social marketing, that we need to preach this message of caring of ourselves until we understand how valuable we are and how much the patients need us intact. So may God help us all. I know the temptation of compassionate care and end up sacrificing our soul and life. The temptation is so high. But sometimes, John Maxwell says, sometimes it's good to say no to good things so you can say yes to greater things. Sometimes Valuing yourself is the greater decision you can do and taking care of ourselves. So with that said, thank you so much. We are looking for another year. We hope we will have something special on the table, but chances are high we will be investing now in applying all the theoretical didactic information we've been receiving in the past 3 years into practice, investing more of our time now in discussing real cases on the ground in most of our sessions, and less didactic presentation, more cases, so we can practicalize this and then help one another equip and skills ourselves to see how other people are doing. And we are inviting more people to come and join us. We will not stop talking about palliative care until we die too. We need to preach the message, because the whole business is all about improving people's life. Last but not least, we are here to change one soul at a time. Let's love one another. Let the spirit of Ubuntu be implanted in our souls so we can love one another. There's what he calls a sixth sense that helps you. I feel like. And then we take care of ourselves and we'll be able to take care of others. One scripture says, when you give to other people, that one is pressed and shaken down and overflow. Can we love ourselves and care for ourselves and give to other people from the overflow? Thank you so much, colleagues. See you next year, 2026, and wish you for a good festive season as you ponder about 2026. Let's continue to take care of our loved ones, and we hope to have moment. For anyone who may want to get certain concepts, visit my YouTube channel, Mahlangu MNS, and then you will get all the recorded videos, including this one. It will be uploaded there for anyone who may want to get it. Also, the materials we've been presenting, they are there in the platform. So you can go to our iEco, and then you'll be able to access the materials we've done for any presentation and use anytime you want. Thank you so much, colleagues. Have a great day. Bye. Bye.
Thank you.